Hey guys, Woodruff here. We're hanging in there, still getting this diabetes lecture done. Maybe it makes you glad if you are in my class this semester that we're doing this all online instead of in person, as this is a very long, there's a lot to this lecture. So I feel like I've been here all day recording this thing. Um, but this is why, like, people always assume since I have this YouTube channel and I make all these videos that I must love recording videos. I actually do not. I would much rather teach in person, uh, but I hate sitting in front of a screen or talking to no one. I would much rather, you will never catch me doing a hybrid course because I always love in-person, face-to-face stuff. There's just something that's much different and much more special about it. But anyway, this is part of my long lecture. Maybe I'm on part 7-ish. I can't remember. I've lost track. 6 or 7, somewhere in there, of my diabetes long lecture. This is my new lecture. It's over. This section is going to be, we just got done talking about insulin. Now we're going to talk about oral medications. I'm hoping it'll be this video and then only one more that's going to be about lifestyle changes and other teaching for diabetes. So I'm hoping this is my next to last video. So if you're watching through this and saying, gosh, how much more can this lady talk about diabetes? We're almost there. So this video is going to be all about oral and other medications that we can use for diabetes aside from insulin. So we're going to be talking more, a lot of these are going to be more for type 2 diabetes, whereas, we talked about type 1 diabetes, they're always going to need insulin. As a warning, because I've been sitting here all day recording these, I also, my husband has a meeting coming up for his work. So it is, I would say, 50% possible that my son's going to interrupt this video, and or you might hear a cat howling at my door because she's very stubborn and takes after her mother, and did not want to come back in the room, but she doesn't want to be in the room, but she doesn't want to be outside of the room. So can't win. So if you hear, demonic howling or yelling, or if my son comes in here and says something really strange, I didn't teach him it, I swear. Anyway, moving on. So like I said, oral medications and other medications for diabetes, because we're going to talk about a couple subcutaneous injections. These are helpful for people with type 2 diabetes. And it's the great thing is that instead of having to take injections all the time, they can be managed with oral medications, which is great. These do, like, I'll talk about this later, but we don't just ever use just medications. Lifestyle changes and other things too, like diet, exercise, are needed. But this is a lot less of an invasive option than constant insulin injections. Now, I know that people that are on oral medications when they're in the hospital, a lot of times are taken off of those because they might be NPO and other stuff, and a lot of times they're put on insulin in the meantime, and also because their blood sugar is more elevated because they're sick. But this is a great option that's less invasive, that long-term can lead to a lot of improvement for someone with diabetes, like I said, type 2. So this is a list. I'm not going to go through all of them because it doesn't really matter. Don't sit here and get too deep into the patho of how each of these work. Some of them are going to work in the GI tract. Some of them are going to work in the liver. Some of them are going to work in the brain. Some of them are going to work in the kidneys. Some of them are going to work in the blood vessels. Some of them are going to work in the fat. Some of them are going to work in the pancreas, maybe. So, lots of different places that things can work. But just keep in mind that it's not so much about where they work. The only reason that where they work matters, and I might bring it up, is just to help you understand like side effects and precautions. But for these meds, what I really want you to hone in on, rather than exactly how are we utilizing insulin more? Is it helping cells to be more receptive to insulin? Is it doing something in the liver to store or manage insulin a little bit better? What do you call it? Glucose better. It doesn't really matter. That the end goal is that all of these are going to cause low or decreased blood sugar, yay. But what we really want to think about is based on where it's working in the body. Like some of these work in the kidneys. Like, is it going to lead to kidney issues, or is it going to lead to liver issues where I need to watch my liver function more? So like focusing on that. So I'm going to try to hone you in on, how do I know it worked, which for all of them is low blood glucose. And then how do I know there's a problem with this medicine? So really focus in on how do I know there's a problem with this medicine, or what's different about this medicine compared to the other oral ones. Let's see if I can move forward. Come on. There we go. All right, so we're going to start with metformin. This is probably going to be one of the most common diabetic oral medications you're going to see given. It is considered a first-line treatment. In other words, it's the first one most doctors go to. And the great thing is it can be used for diabetes, or it can also be used for pre-diabetes, which we talked about before. And the cool thing, like I mentioned, with the cool thing about pre-diabetes is that we can actually prevent it from becoming full-blown diabetes, or at least delay it. And metformin is that drug of choice for that pre-diabetes. So how will we know there's a problem? Because again, we're always looking for what's different. So I'm just trying to highlight what's different. So you're going to notice in most of these, I could say, hey, hypoglycemia, but they're all going to cause hypoglycemia. Now, I'll tell you, metformin does not have as much of a hypoglycemic effect, but it is possible. But I'm trying to really point out what's different, or what you're going to need to assess for, ask, look at to see if there's a problem. So one thing to know about metformin is that it can cause GI upset like diarrhea, especially like one of the ways that it works is in your stomach, where it stops you from absorbing so many carbohydrates. But because that anytime your body doesn't absorb something, you poop it out. So the patients can have a lot of diarrhea, especially with high carb meals. So a lot of times they need to look at what they're eating if they're having a ton of diarrhea. There also is a very rare but very deadly issue that they can have, which is called lactic acidosis. And what happens here is effectively you convert to a different type of metabolism in your body. You don't need to understand all that, but it can lead to very serious acid-base other imbalances and shock and other stuff that's not fun. So what you really want to be looking for a patient showing this, they would be having muscle pain, a decreased level of consciousness. They may have an increased respiratory rate. They're breathing faster, trying to breathe off that acid that they're accumulating. So you'd be looking for those signs. We can prevent a lot of the GI upset if they take their metformin with food, and then also kind of look if they're having a lot of diarrhea, again, looking at what foods they're eating, because these meds aren't meant to, and same with insulin, we're not meant to, hey, let me just take a whole bunch so that I don't have to, so I can eat whatever I want. We want to have to also look at the foods and choices that they're making. To prevent lactic acidosis, a great way to do that so that acid can accumulate is to stay hydrated. Think of the same thing like diabetic ketoacidosis, where we need the fluids to kind of flush out or kind of dilute those that excess acid that's in the body. It's also, as a whole, it's not for people with kidney, liver, and disease or heart failure. Now you might be like, isn't everyone with diabetes, didn't you say everyone has kidney issues? Yes, to an extent, but we definitely, for people that are not diabetic or pre-diabetic, we definitely don't want to but utilize this, as it can lead to a lot of serious issues for these patients. It's going to be a risk versus benefit thing, but we definitely want to notify a physician if a patient has kidney, liver, heart issues, if they're going to be put on metformin. And then the other thing, and this is definitely something to note, I've seen a lot of test-like questions, NCLEX-like questions around this, is that if someone's going to receive IV contrast, like they need to get a CT scan or an MRI with IV contrast, that's really hard on the kidneys and can lead to damage to the kidneys. But using it with metformin kind of like doubles, triples, intensifies the risk of kidney damage. So what we do is we take them off their metformin a day or two before they're going to get the IV contrast, and then they need to stay off of that for 2 days after the IV contrast. And we flush out their kidneys. We give them a lot of fluids and stuff to try to keep them hydrated to prevent their kidneys from getting hurt in this exchange. So effectively, there's the GI side effects. We want to keep them hydrated, and then watch out for those serious effects with IV contrast, or if they have those other conditions. So then there's the sulfonylureas. These work in the pancreas, and that's glipizide and glyburide are to the names. There's a mnemonic there for you. And so the main side effect of this, now I told you I wasn't really going to put hypoglycemia in as a side effect, because they all can cause hypoglycemia as a whole. Metformin, like I said, not so much, but this one has a very profound hypoglycemic effect because it increases your insulin production. So it has a much more profound and sudden effect. So we definitely want to be super careful, and they need to take this 30 minutes prior to meals in order to help to combat that hypoglycemia. We also can have weight gain with this, which can definitely, like with the metformin, they can actually lose weight with it, whereas with others, you might see weight gain. So it's just something to keep in mind, because a lot of these patients can't really afford to gain weight. So we have to kind of be cautious with that. You're going to see me kind of zipping through. There's a lot of these. We're going to make it through. So there's the meglitinides, meglitinides, excuse me. I'm not gonna be able to pronounce most of these to save my life, but luckily I'm not paid by my ability to pronounce names. I will let you read some of them, but I remember meglitinides because you must eat great. So what's different about this medication is that you need to take it within 30 minutes or less of a meal, just like with the sulfonylureas, but you cannot take this if you're going to skip a meal. You have to, what do you call it? It's going to increase the insulin production in the pancreas, just like the sulfonylureas, but it's more of a rapid. It's not going to it's not going to have as severe of the hypoglycemic effect as, what do you call it? The sulfonylureas are, but it's only for if you're going to be eating, because it, what do you call it? It definitely helps to lower your blood glucose after that meal. But if you're not going to have a meal, you should not be eating this. Sorry, let me make sure I said, if you're not going to have a meal, you should not be taking this. There you go. You'll know there's a problem with this med. Again, it's similar to the sulfonylureas. It can cause weight gain. So there's also what's known as alpha-glucosidase inhibitors, like a carbose. That's probably one of the few I can pronounce. The big thing to look at with these is these slow your absorption of carbohydrate. I can't know I can talk, but I think it's because I've done so many of these back to back of carbohydrates. So in other words, like the name implies, glucose is inhibited. So or A, like a carbose is A is without without a carb, is without so think without carbs. But what you have to imagine here is that kind of like with metformin, if I'm blocking the absorption of carbs, I can have a lot of GI side effects. These work by slowing my intake of carbohydrates. So it's not like, effectively, if I took a bunch of carbohydrates in, it's going to slow down how much that I am, what do you call it? Absorbing those actual carbohydrates I'm taking in. But in order for this to work, I have to actually have carbohydrates in my stomach, or I should say in my intestines. So these have to be taken with the first bite of every meal. If I don't take them with meals, how are they going to work? Because these are working by stopping me from processing so many carbs. But again, if I take this and I have no carbs inside of me, there's nothing that this medication can do. So these have to be taken with the first bite of every meal. All right. Ooh, practice question. We're going to take a little break because I think I put this in here because I was like, it's so hard, all these meds back to back. I'm trying to move my face around so I can see. So nurse is caring for a client who is scheduled to receive their metformin. Which of the following laboratory findings will require the nurse to take further action prior to administration? So really this is looking at, like, I am about to give a patient metformin. Which of these labs is going to stop me from being able to give it safely? Like, which of these would I have to like take a pause and be like, let me call the doctor, let me investigate this more. So let me see which of these is related or could cause problems for a client on metformin. So the first one is a potassium of 3.3. So this is abnormal. And I definitely don't want people's electrolytes to be abnormal. But is a potassium of 3.3 going to make giving metformin unsafe? In other words, if I give them metformin and their potassium is 3.3, could it cause harm? And while I do definitely want to replace their potassium, metformin and potassium, they don't work the same. Like it's not going to cause their potassium to get lost. If this was furosemide, I would have to hold it, but we're talking about metformin, so it is not a concern here. The next one is creatinine 1.9. So that is abnormal too. It's elevated creatinine. And I know there's stuff with the creatinine or the kidneys, and creatinine is a measure of kidney function. There's stuff that I worry about kidney function and metformin. So this is kind of a red flag. So far, this is one that I think is possible, but I'm going to keep looking. Next one's cholesterol 205. So you may not know your cholesterol normals yet. Don't worry, cardiac's coming. Know that this is abnormal, above 200 for, this should say total cholesterol. Above 200 is abnormal. So this is abnormal, but I have to again think, okay, this is abnormal, but is having a high cholesterol a reason not to take metformin? Not necessarily. I mean, keeping my blood sugar under control, it sounds like I need to take it. I might need a different medicine to help with the cholesterol, but it's not going to necessarily, the metformin is not going to affect it. Last but not least, I have blood glucose 215. So some people may stop and say, well, no, I'm not going to give metformin. I need to go give insulin, or I need to give something else. And I don't know, maybe I do. But it's really just asking here, is it unsafe to give metformin if my blood sugar is up? Well, no, I mean, it sounds like exactly the reason to give it. So sometimes, like for example, in future exams, like for cardiac, we'll have something similar to this question that'll say like to take your atorvastatin, which is a cholesterol med, and then we'll have which of the labs would require you to take further action, and it's like a high cholesterol. And some students say, "Oh no, it's high. The medication's not working." And I was like, "Well, maybe they just started on it. I don't know." But you have to think about, why am I giving this med? I'm giving metformin to lower their blood glucose, just like I give statins and things to lower cholesterol. And so, if anything, this is a reason to give the medication. Now, do I maybe need to check in with the doctor and just make sure if this is kind of where their blood sugar is staying? Maybe they do need something else, possibly, but it's not a reason not to give. It's not a contraindication. It won't cause harm to give the metformin if their blood glucose is high. So the only one of these that harm could happen if I give the metformin is the creatinine being elevated, because with that elevated creatinine, it definitely can get worse, and metformin can be hard on the kidneys. So I may need to check in with the doctor to make sure that they are aware of the creatinine being elevated before I administer it. So B is the correct answer there. All right, let's get into some more oral medications. I think there's only 15 more. Just kidding. It's not that many. So now there's DPP-4 inhibitors. These work in multiple areas of the body to effectively have less glucose and more insulin. These all end in gliptin. So the thing that's different or special about this one is that that they can have upper respiratory symptoms like infection issues. They're higher risk for upper respiratory infections. And they also are higher risk for pancreatitis. So the teaching I would want to give here, is just to report any symptoms that they're having that might indicate pancreatitis, which is like nausea, vomiting, left upper quadrant pain, things like that. So want to watch for those closely. Then there is also SGLT-2 inhibitors. And these are the Flozin medications, and this is one of my favorite mnemonics of all time. Is that I came up with the sugar gets left in the toilet for SGL2, because the way that this one works is it helps you to get rid of sugar, the excess glucose through your urine. But one of my students one semester came up with this great mnemonic that sugar is flozing down the toilet. So you got to love it. So thank you very much. All credit to you. So how are we going to know there's a problem with this medication? We're going to watch for, urinary infection. So we're going to look for that frequency, urgency, burning, that kind of stuff that could indicate a UTI. And then also something else to consider is, as I'm losing all this glucose through my urinary tract, I'm losing a bunch of glucose, so I can have severe hypoglycemia. And then also I'm losing volume, I'm losing fluid, because remember that volume always wants to follow the glucose. So they can also lose volume and have a decreased blood pressure. So I'm going to tell this patient to change position slowly. All those signs and symptoms of a UTI. They should take it first thing in the morning, because it kind of has almost like a diuretic effect, and we don't want them to be up all night or falling down in the middle of the night, especially because it can lower their blood pressure. They can have like orthostatic hypotension. It's not a diuretic, but it acts a lot like one. And then stay hydrated, because they're losing volume too, so we want to make sure that we're replacing that volume. All right, I think this is the last one. I think I'm not lying to you. There's also subcutaneous injections. So these are like insulin, but they work a little different. It's not something that you're going to take in relation. And I should mention that too, so with insulin, we talked about how you take insulin based on what your blood sugar is. There's like that sliding scale. There's not a sliding scale for oral medications. With oral medications, it's not like, oh, my blood sugar is this, so I take this many pills. It's just like you have like a maintenance dose. But just make sure to pay close attention. I also talked about, I'll talk about this more when I talk about sick days. When you're sick, normally you always want to take your insulin, but with some of these oral meds, if you're sick and not eating, like we talked about, there's some of these you're not going to take, but I'll get more to that when I talk about sick days. But anyway, so this GLP-1 receptor agonist. So it's a sub-Q injection like insulin, but it does not work like insulin. The way this one specifically works, there are some injections that are like insulin. They're called like amylin analogs and stuff like that. But this one works a little differently. This one works because what it effectively does is it slows down how quickly that you're absorbing what do you call it? Your carbohydrates and other nutrients. So in other words, it slows down your gastric motility, and this helps because it slows down how quickly you're absorbing that glucose. Well, this is great for my blood glucose, but it can also, if I'm taking other pills while I'm taking this, it can affect the absorption of those meds too. So I do not want to give this at the same time as other medications. And also because it's affecting my GI tract, it can lead to other things like nausea, vomiting, because they might feel more full because they have less gastric emptying. Think of this like the diabetic gastroparesis. And then can also lead to things like diarrhea as well. So watch carefully for hypoglycemia as well, since they may be absorbing things slower. And then, like I said, no other medications within 1 hour. There's a lot of other medications that affect diabetes. We talked about beta blockers, how they can mask the symptoms of hypoglycemia where they're blocking that sympathetic nervous system reaction, so I don't know my blood sugar's low. Then we also talked about steroids that can cause hyperglycemia. Always remember steroids and hyperglycemia. I know I've said it like 5 times, but it's amazing. A lot of times I say this 5 times and people still forget it. Always remember, you're going to need to carry this with you everywhere you go and every semester. Steroids, hyperglycemia. But one other one I haven't talked about yet is that thiazide and loop diuretics, everything that the way that insulin, glucose, potassium, they all kind of interloop together. So patients that are on thiazide and loop diuretics have a lot of potassium loss, but as a result of that, they can also have hyperglycemia. So watch out for patients taking those that they might be have a more elevated blood glucose. Okay. So let's do a matching here. Let's see if I can remember these because I might have to cheat and look some of them up because I don't think I have all of these memorized yet. Maybe I can hopefully like narrow them down. I think I got most of them. I was trying to study this last night. I was like, so I didn't get here. And then I was like, oh, so yeah, anyway, let's look. So the first one is so there's a statement on one side and then there's the drug on the other. Let's see if we can match some of these. So the first one is report any burning frequency or urgency of urination. So I think that's the one where we're worried about it going through their urinary tract. They're more high risk for infections. It's that Flozin one. So I see down there the Kangaflozin is going to be correct phrase. So Kangaflozin, which is the one right here, is going to be A. So the next one, it says report left upper quadrant pain. So this is the one that causes the left upper quadrant pain is the one that can cause pancreatitis. And I feel like it's the gliptins because it's the DPP-4 inhibitors. So let me see if I'm right here. Let's check back without cheating too much. Gliptins, yay, I got it right. Woohoo! And that's the pancreatitis one, right? Okay, yeah, all right, so I was right. See, I had to cheat a little bit, but this is life. Don't think us nursing professors have it all figured out. There's a lot of meds, and these are not ones that I give all the time because most of the time in the hospital, people are getting insulin. So left upper quadrant pain is this sitagliptin. So do not take if you're going to, this is where I'm going to start getting confused. Do not take if you're going to skip a meal. So this is the one that's like there's the sulfonylureas, which can cause the profound hypoglycemia. Then there is the meglitinides, which is must eat great. So this is the glinides, and I want to say it's going to be this repaglinide. Let's look. Let's go back. Oh, let's see. Oh, I was right. Must eat great. Do not take if you're going to skip a meal. Woohoo! I'm getting them all right. So far, so good. That's how y'all feel on exams where you're like, I got it. So anyway, then we're on D, which so far we have Kangaflozin for A, we have the sitagliptin for B, and we have the repaglinide for C. So take with the first bite of every meal to slow absorption of carbohydrates. So this one I actually do know because this is the one where it is going to, you want to take it with the first bite because it's anti-carb. So I always remember acarbose without carbs. So acarbose is D. Then we go on to stay hydrated to prevent complications of this medication. So that's the one that we're worried about, lactic acidosis. So that's going to have to be metformin. Now, I know some people might say, "Ooh, you also didn't you say that for cangaflosin?" Yes, it's true, but you have to think about which one is the best answer for this, and the only one that's left, and we already used cangaflosin. So next is we have give within 30 minutes of eating due to profound hypoglycemic effect. So this is going to be my sulfonylurea, which is glipizide or glyburide. So we have glyburide here. So glyburide F. And then last but not least, it's do not take other oral medications within 1 hour, I should probably say 1 hour of this medication. So I think that's going to be my, the Tide, because I think the Tide, like it's the GI one, right? Yep. Exantide, something like that. So we have cangaflosin for A. We have the sitagliptin for B. We have the repaglinide for C. We have the acarbose for D. We have the metformin for E. We have the glyburide for F, and then we have the exenatide for G. Hopefully, that makes sense. Okay, that is the end of this oral medication PowerPoint. We have made it through diabetes main medications, and now we're going to go into all the other teaching and things we can do for diabetes. Hopefully, last video, we're so close. I'll see you guys for the next one.